Good morning, everyone. Welcome to our live discussion about crisis and warm lines here in California. It's Suicide Prevention Month, September, and so we thought it would be a good idea to bring together some folks to talk about 988 and our crisis continuum at large here in California. Both crisis lines or call centers, as they're commonly referred to, and warm lines have an important role in our crisis continuum. And so we kind of wanted to talk through that with our two experts here today and have a conversation. So now that we've given people a moment to join, we'd like to get started. I'm going to introduce you to my panelists here. Dr. Jonathan Porteus is the CEO for WellSpace Health. They operate one of our statewide call centers that recently transitioned over to 988, but they've been doing it a very long time. He's a statewide leader in integrating healthcare services based here in Sacramento. And we're really honored to have you join us this morning. We know you're really busy. And then we also have Raina Daniels joining us. She's from the Associate Director of Outreach and Partnerships of Mental Health Association of San Francisco, and they run one of the non-emergency warm lines for emotional support here in California. So both of these, like I said, are critical services and play a great role in our crisis continuum. And so we're excited to have you here today. We're all first timers to this Facebook Live thing, so hopefully it'll go smoothly without a hitch. I'm going to start with you, Dr. Porteus, if you don't mind. What role do you see call centers playing in the crisis care continuum?
Thank you, by the way. It's an honor to be here. It's a treat to work with Raina and with you. Thank you so much. The crisis care continuum probably has one front-end decision to make. It's about lethality. Is there a life about to be lost or not? Beyond that, we need a true continuum. If you imagine a slide or a conveyor, where people are met with the appropriate level of support, the appropriate qualifications, and some compelling way to know that we are going to be there for them across time. The goal of a crisis care continuum is to ensure that someone isn't just bouncing off a system, but they're actually coming into a system. I think that's where the partnership with warm lines and suicide prevention crisis lines can do really amazing work.
Thanks. I'm going to move over to Raina now. So while warm lines don't necessarily answer crisis calls, they do play an essential role in kind of the prevention end of our continuum. And where do you feel like the warm lines fit? And especially as we think to the future now that we have 988, where do you see warm lines fitting into that continuum?
Yeah, thank you. Thank you for having me here as well. It's really great to join you both. The California Peer Run Warm Line is available 24/7, 365. And I think that availability for folks, it does match the 988 system. But when we think about callers to the 988 or to the suicide prevention program directly, we're thinking about folks who are identifying that they or that someone that they care about is in an immediate crisis of some kind, or that they are dealing specifically with suicidality. The warm line, if you think about that being a boiling pot of crisis, the warm line is really meant to help support folks before they get to a boil, to help folks reduce their simmer, to cool things down, to develop strategies, to offer listening and support that can be part of someone's ongoing wellness or maintenance pre-crisis. And so, yes, it's prevention service, and it's also an alternative service entirely.
Great, thank you so much. In terms of the warm line, like who's calling? I mean, you kind of said that, like the folks, that's a great analogy, this kind of simmering pot. And who answers your warm line?
Yeah, I think that's one of the things that makes the warm line programs and peer support programs really unique as well, is that everyone who works in our program, all of our staff, have lived experience of mental health challenges themselves. And so they are in recovery in their own journey, in a position where they have been both supported in order to be able to provide service outside, and also rigorously trained in peer-delivered services specifically. And peer services looks a lot different than services being delivered by clinicians or by folks who haven't experienced their own mental health challenges. our peers can identify with the struggle of both the mental health challenges themselves and also navigating the systems that are so difficult for receiving support. They provide a relief for isolation as well. Many folks who are experiencing mental health challenges or emotional issues or just, boils of any kind, they don't feel like they have necessarily someone who they can rely on for non-judgmental listening, for reflection, for debriefing, or just like venting. And those are services that our peers are just really skilled at providing, and really recognize themselves the value that those things play in their own wellness. So it's very reciprocal. It's a very reciprocal relationship that our peers develop with their callers.
That's really beautiful. I love that. I love, as we think about all the workforce challenges that we're seeing, post-COVID for so many sectors of our of employment, I think peers are a key answer, and people with lived experience for, especially at this level of our care system, the kind of prevention side. So thank you for that. That's amazing. Kind of a similar question for you too, Dr. Porteus. If you could tell us kind of who's answering your the call center lines, and kind of that model as opposed to the warm lines.
Yes, well, because of that front-end lethality assessment, we do have certified suicide prevention specialists responding. So we have a very sort of elaborate science-based intervention strategy. It's kind of a cognitive behavioral strategy for telephone response that's nationally and internationally recognized. And we do this to assess for lethality and then triage accordingly. So there's a whole range then of people with mental health licenses, also people with lived experiences. So what we try and do is assess very quickly where someone is on the continuum of crisis, kind of how much is boiling up, to use that analogy, and then provide the right mesh. But we have people who are certified suicide prevention specialists, we have licensed clinicians, but then I would say that 95% of the calls that we receive get resolved in some way through our crisis response line, because we have the whole range of folks, including people with lived experience. Then ultimately, we do encourage the use of warm lines in the future, and that's that connecting that we do. There's this really important concept that people are using around air traffic control level communication, and it sounds a little odd, but if you imagine a plane flying in the sky and one control tower is passing the plane to another, the control towers communicate. Even once the one has passed the plane on, they double check to make sure they're still in touch with the plane. And all too often, the people we serve who are in crisis or moving on from crisis are dropped, and we want to make sure that they're continued. That they have continued contact, and that's where I think connecting with the warm lines and other services is critical.
Great, it's a really important point to make, and I think it's one of the questions we've kind of heard from the community about, like, now that we have 988, what does that mean, and how are the warm lines and the call centers going to connect? And I think we haven't quite figured that out, but I love the vision of having those connections made between crisis and warm lines, both ways, right? Like either way. So now that we kind of have talked a little bit about the continuum, as I mentioned at the top of the show, it's Suicide Prevention Month. And so we want to kind of talk about how these services play a role in suicide prevention, and maybe if each of you could kind of speak to, because you are two folks who run warm lines and call centers, but there is a whole web of these types of services throughout California. So if you could just speak to a little bit the breadth of that as well, that would be great. And maybe we'll start with you, Raina.
Sure. Yeah, so I'm understanding your question is just about how the warm line services or how phone services specifically fit into suicide prevention. I think that, I mentioned right off the top, and always repeat our availability, because I think that that's one of the essential elements, is this 24-hour, 7-day a week, 365-day accessibility of the service. We have both bilingual Spanish speakers on our line, and we have a language interpretation service with 240 different languages. We are a program that is available at all hours of the night and day for folks who are in need of emotional support. And I think that is suicide prevention really at its core. That if someone is having a hard time keeping themselves safe, if they're having an emotional upheaval, that they really need immediate support around, that is what our service is designed both to address and to coordinate. We do, in the ways that we are networked right now with the National Suicide Prevention Lifeline, the service that's become the 988 program, we provide three-way calls and warm transfers to that service when our callers are wanting to be connected to the suicide prevention line specifically. We provide referrals and make sure that folks have access to information about other services that might be helpful. We can help direct them to emergency service or walk-in services and walk them through what our counselors experience and what their training tells them, maybe the experience that caller would have upon intake, kind of just really walk alongside folks in those moments where they're struggling.
And you may not know the answer to this, so feel free to just say that. Do you have any kind of estimation of the number of warm lines we have throughout the state of California?
That's a great question. One of our goals in the next year is to really coordinate more with the warm lines throughout the state of California specifically. I sit on a monthly call, a Zoom meeting, of course, with warm line leaders from all over the country who have been organizing around best practices and current practices. And that coalition building really has not been financially supported or a part of the framework of the development of independent warm lines. I think if you don't mind, I'll share just a little bit. I think that the foundations of the warm line services are really important to understanding some of the differences between our programs. The majority of warm lines of peer-delivered mental health programs developed out of the peer movement themselves, and we're talking about grassroots organizations formed by folks who had themselves been usually drawn to advocacy around mental health reform or providing peer support for other folks who are struggling because of the lack of services that they saw, or perhaps the harm that was caused to them by the services that they accessed in the first place. And so warm lines began as phone numbers, as front desk phones, as back office phone lines that were available to folks to call. And some of them have limited hours, limited availability. Many of them have not been a part of the formalized funding for state and mental health programs, both for nonprofit and corporation reasons and funding scarcity, but also because peer-delivered services have not been designated the value that medical model or clinical delivered services have. And I think that all of those things have contributed to warm lines not being part of the integration of 988 services. Up until this point, the Lifeline programs have operated independently. I know that there are some 200 odd programs that answer the 988 service as well. And many of those organizations are founded in substance use treatment programs, other clinical mental health programs. But then we have partners at, for example, NAMI, the National Alliance for Mental Illness, which does a lot of friends and family support work, a lot of early intervention work as well. And that's, again, they're another complementary service. They're available. We talk mostly to peers, to the folks who are experiencing the mental health challenges themselves. That's the core of our work. NAMI is available as a referral to talk to concerned friends and family members. Yeah, we're all part of a very large web, I think, when it comes to prevention. And when we think about the roots of suicidality, a lot of this has to do with isolation, with a lack of alternatives. And I think that the lack of support that folks feel really can be alleviated by having anybody available to call who's going to be non-judgmental and supportive at any hour of the night.
Great. I think, that connection is so important. And I think, we all saw isolation. Isolation was already an issue for folks who were struggling. And I think, COVID just grew that exponentially. So I think that connection is such an important piece to highlight and make sure we have. What about from you, Dr. Porteus? I think it's a very similar question. How important is it for folks to have someone to call immediately, whether they're in crisis or not?
Well, in the case of suicide prevention, it is truly life-saving. So I think if you look at the history of how we have come to be, it's interesting. The folks implementing 988 in Texas called the state of California and said, "Hey, how are you doing this?" And the state said, "Let's ask our suicide prevention specialist to answer that question, because it's never been a true part integrated into the state." And so, listening to Raina, I realized that we have collectively built a system of response since the early 1950s that is addressing suicidality and mental health crisis, and has never been a formal part of our response system in the state. So this burgeoning need for a true understanding of how we help people across a continuum, to use her metaphor, from a boil to a simmer, so to speak, is critical. There are 13 crisis centers in the state of California. We are collectively a consortium called 988 California, and you can find us at 988ca.org. And we represent a group of people who are nationally accredited. We follow all the accreditations and certifications of what it takes to be a suicide prevention crisis center. And we work very hard on that collaborative approach so we can be 13 regional centers. All of us have kind of a statewide scope, most of us. For example, my organization serves all 58 counties in California and some overflow from the rest of the country. But we're really working on that relationship. And it's just interesting hearing that our colleagues who are running the warm lines are doing the same thing. And it speaks to how we all noticed something over decades that was needed, and we built it. We didn't really have traditional funding streams. We just built it. And we built an incredible program of warm lines and suicide prevention lines that has now become the backstop for crisis response across the state of California.
Yeah, agreed. And what an opportunity, COVID has given us in a way with the growth in Zoom connections and the fact that you all can make these connections nationally with other folks doing the same type of work and learn from one another and connect on your own level with those folks doing the same kind of work. So thinking about COVID-19, what are you, as much as we'd all like to stop talking about it and believe that it's over, we all know that we're still kind of dealing with, our own varying levels of risk in our communities. And what are you seeing in both, the call center side and the warm line side as a result, at this stage in the pandemic? Maybe you can go first, Jonathan.
Okay, well, COVID obviously is a public health emergency, but it has been a mental health crisis as well. It has forced separation, and we are not creatures who should be separated. Humans are built to be connected. Our whole neurologic system is geared to connection. Our neurons are built to connect with others, and so COVID has had deep, damaging impact on people, especially young people who were forced into isolation, forced apart. They were not able to engage socially with each other in teams. And now the reintegration. We know that people have a really hard time when we talk about attachment. Attachment is not just about how we separate from people, but it's also how we reintegrate with people. And the reintegration is hard. On top of that, I think we've seen major crises, other pandemics, the pandemic of racism, and during this time we've seen huge uproar around matters of diversity and inclusion across our country and across the world. We've also seen a climate crisis that adds to it. And as a parent of teenagers, it frankly is hard to look at the future through the eyes of a teenager. The isolation, the identity matters that a lot of people don't wish to look at, and the state of our climate and the planet in terms of the environment. So I hate to get sort of political that way, but we do have a total crisis, especially for young people.
Agreed. I think we're seeing that reflected in every sector of our society, and I mean, fortunately here in California, we're seeing a huge investment in children's mental health and youth, and that's really great. But I think these conversations are so important about the reintegration of our children and youth back into reconnecting with all. Do you feel like things are improving? Are you seeing a difference in call volume or other things that make you think we're coming on the other side?
I think warm lines play a particularly important role in this reintegration process.
Mm-hmm.
It's about the simmer. It's about a lot of young people are not even given the ability to see themselves as important. And so they may not even see themselves as being in a crisis to call a crisis line.
Mm-hmm.
They may think that there's some sort of thing that's important to them that they're more likely to call a warm line for that kind of support. And so I think, and that's really helpful because it helps the simmer not become a boil. Sorry, I keep hanging on to your metaphor, but it's perfect. So yeah, I do think that the warm lines play a particularly strong role with youth.
So maybe we'll switch over to you then, Raina, and just kind of have you, what are you seeing at this stage? And do you see any indicators that things are improving, or we still have quite a ways to go?
Yes, thank you. I think the crisis point of isolation is really not over for many members of our community. The contagion risk among folks with disabilities or any health condition that makes them especially vulnerable to the effects of the immediate COVID infection are still very high. The risks of long COVID that have been shown now to have effect on folks' mental health in the long haul are still being looked at and are very much confirmed as well. Folks are calling us who are experiencing mental health distress that they had not previously had before coming down with COVID and recovering and developing long COVID symptoms. I think that we still speak to very many people who are struggling with grief, who have lost folks to death from illness from COVID, and who are also grieving. Grief is a very large term for an experience of so many folks who are just letting go a way of life that they don't have access to because of ongoing contagion risk. I think that we really are in a new era, and so the question of recovery or improvement is really a different one if you consider that it's an evolution of the needs that folks have for connection, the needs that folks have for protection, and the community-based need for accessing accurate information and also reflecting that accurate information back with other folks that they care about. When we look at our top caller needs, we are, and we track this just very generally about the caller concerns addressed during the call. And our top 5 needs are interpersonal relationships. And so that's not just immediate familial or romantic relationships. That's what are relationships with other people doing that are causing someone to call. Isolation, anxiety, general mental health, and COVID are all still our top 5 concerns for this year. And those, I think those reflect COVID calls that don't necessarily have to do with the virus itself, but other issues, I think, Jonathan did a great job of addressing those larger systemic issues. We're looking at economic stress, like I said, public health measures and the lack of adherence to public health measures or conflict about public health measures interpersonally has been very isolating for many people. Folks have been, distanced from friends or family members, from members of their household in navigating their own, what I call COVID math, figuring out your safety, your very specific safety metric. But economic stress, the place that we're at with the housing crisis and with climate crisis, those are very real concerns that self-care and community care can only go so far to address. And I think that what we do on the Warm Line with our callers is we also hold each other through this very challenging time.
Yeah, so important, so important. Did you have anything to add to that, Dr. Porteus?
Well, I think that the role of the crisis continuum probably needs to include more around these big political issues that are hitting us. I don't want to hammer away at it too hard, but people are being really confused by fact being fiction and fiction being fact, and your sense of who you are gets really fractured when people are literally denying your reality. And many of the people we serve through the crisis response continuum, their reality is denied. And then if they start acknowledging what the things are that they're trying to address, there really are no avenues for them. Raina just mentioned housing, for example. So we've got multiple compounded crises, and we're picking up on them.
It's a really great segue into the next kind of piece of the conversation that I wanted to talk about. And it's like the famous therapist line, like, what if you had a magic wand and we're creating our crisis continuum for the state of California and beyond, for that matter, in our perfect state, what would that look like? What would we need to fix and develop in order to have the perfect kind of continuum of care for someone at risk of entering a crisis or in active crisis for California and beyond? And maybe I'll just start with you, Jonathan.
Okay, well, prevention. That's not the crisis care continuum, that's prevention. That is stopping anyone from ever getting beyond some sort of anxiety to even start simmering, and all the way up to boiling. So prevention is critical. The warm lines play a critical role with that. Education, understanding, resource acquisition, these are all parts of prevention. A crisis continuum, if we start from kind of the most extreme, we need a continuum that addresses acute intoxication, acute behavioral health crises that include psychiatric crises, psychosis, substance intoxication, issues around true suicidality, just people being suicidal. But the way that the 988 system has been now brought together is that all suicide prevention and mental health crisis is coming in to this one system. So we need a way of responding to all crises, essentially. And then for me, and I'm sorry, I'm going to belabor this point, but we've kind of developed something which we kind of think of as a special for California, because we've been doing this since the early 1950s. We need a continuum that really creates support. We need, if you follow kind of the federal guidelines of how you respond to a behavioral health crisis, you need a front end certified suicide prevention, lethality assessment, mental health crisis triage. You need crisis receiving sites, places where people can go other than a jail, other than a hospital, not with a law enforcement provider. I call them providers because we've turned law enforcement into providers. We need alternative destinations for people in crisis that don't treat this like the end of the road. A psychiatric facility is unnecessary for 98% of the people calling a suicide hotline. A hospital is unnecessary. A jail is unnecessary for the vast majority of people who are involved with some kind of psychosis or intoxication on the street. So we need that crisis receiving system. We need coordination and dispatch between the folks receiving a non-law enforcement response to the crisis. And then we need longer-term solutions for crisis respite, crisis housing, and then a broader continuum. A lot of programs across the country, a lot of communities have a mental health continuum, but that mental health continuum doesn't know how to deal with a crisis. So someone starts going into crisis, and they very quickly end up in an emergency room or a psychiatric facility. And that's preposterous. It's just preposterous. The amount of time it takes for someone with a psychosis to actually be seen as having one is like 2 years in this country before the average psychosis is detected. And we've got countries across the world that are looking at 2 months, 2 weeks before that psychosis is detected. So we need that front-end assessment that's real. I think that's the dream of a continuum, is to receive those calls. We see the care court that's become a real focus in the state of California. And I'm hoping that also, that the 90-day crisis response continuum could be the front end of receiving people who've never actually received services, which is kind of what the care court's talking about. And providing support versus a court-like environment, bringing people into a continuum of support. So there's this conveyor we see in WellSpace Health, where we've really tried to develop that in Sacramento County. We see our ability to resolve 95% of all of these crisis calls within our organization, that we've created a continuum. And that continuum is front-end assessment, triage, moving to crisis receiving, 24/7 drop-off, moving to crisis respite and longer-term services.
Awesome. Really great. How about you, Raina? What do you have to add to the dream vision of our crisis care continuum?
This is such a wonderful and broad question. I wish we had the rest of the afternoon to hang out together with this. Well, thank you. I think Dr. Porteus really touched on so many of the dreams that I think anyone in touch with anyone who needs mental health support at any time in their lives really identifies. I wish this person had a respite center to go to where they could get away from their current housing situation or their family member or their circumstance, where they could seek respite with wellness. We're talking about these in-person, non-carceral support responders. We're talking about alternatives to the police or replacements for the police, as they've been set into roles of being first responders to mental health crises. Prevention is such a broad look back. When I think about prevention, I'm thinking about free wellness programs and community wellness programs. But we know that folks need support, and we know that folks who are at the highest risk of both being coerced or forced into care or forced into incarceration, that those folks are more likely to be people of color, people who have experienced poverty. We know about the adverse childhood experiences that lead folks into major health disparity. We're talking about domestic violence and childhood sexual assault and lack of resources, lack of power in the home. We know what the social determinants of health are as public health workers, and also community members know what they are. They call us and say, I'm not having a mental health crisis. I'm not sleeping because I'm about to be evicted. That isn't something that any pharmaceutical, any therapeutic process is going to aid. We're talking about major economic disparity. And so this question of a magic wand is a large one. We as a nation underfund voluntary services. And that is a systemic issue which could be resolved by reprioritizing where we invest. On a federal level, on a state level, on a local level, on a corporate level. But as Dr. Porteus mentioned, there are other models. We know we have great models in other countries who are providing for their citizens in a much more robust way than we currently are. And we are piloting really innovative, wonderful programs that have been showing wonderful results for years, for decades. We know that respite programs and alternatives to police programs, community care programs, and also just economic relief programs work for communities at risk of crisis and suicide. We know that they work. And it's really about how many pilots are we going to do before we really land on a funding and investment strategy that works. I think we as an organization did some advocacy around the care court legislation. I think I would love to just call Sally Zinman into the room. Karen, I'm sure both of you had a close relationship with Sally over the years. She just passed. She was a longtime advocate in the mental health community, founded the first statewide mental health consumer-led organization, been a huge supporter of the Mental Health Association of San Francisco. And she continued, and we're going to continue to say, voluntary person-centered holistic services. These voluntary person-centered holistic services that deal with the whole human being. That is really what the care continuum looks like. But we're not just talking about the mental health care continuum. We're talking about the care continuum of our communities, of our relationships with our resources, which are plentiful.
Yeah, I hate to jump in, but we are introducing reactive measures to helping people in crisis, because we've completely underinvested in stopping it from ever happening in the first place. I just can't agree with Raina more. I'm actually advocating for a program of potentially being coercive, like the care court, because we've never done anything. And so the goal here is to flip that completely, but we have nothing on the front end to stop people in crisis from going any further. And we have nothing to stop people from spending years psychotic before they're even acknowledged. Those years equate to decades of care before someone can even stabilize. It's really heartbreaking. And being the brother of someone with schizophrenia, it's doubly heartbreaking.
Yeah, I think back on my, more than 20 years ago when I was working in juvenile justice, and I had a young man that was actively suicidal, and we were in session, and I was, I think it's time, I think you're going to need help, like you can't stay safe. And to have to call the police and see this young man who trusted me enough to go this route, to see them handcuffed him, put him in the backseat of a police car, take him to a hospital where he was underage and wasn't placed for several days, to think about the compounding trauma that our system inflicts on people that we're trying to help get better. It does feel like insanity. It doesn't make, if we were creating a system to care for people we loved, none of us would create this system. And it absolutely, we have these disparities in terms of, socioeconomic status, racial disparities. And I think this lack of adequate access to the care that people need for their mental health crises, their substance use disorders, any of it cross-cuts all of that. I think whether you're privately insured or publicly insured, there's not enough care available at any level of our continuum. And while I have appreciated the growing budget investments in this space, to both of your points, it does feel like the prevention side continues to get a smaller percentage of the whole than we all know would make kind of the biggest difference. So I think that's a really important point. I mean, I think the farther upstream we can get, the better outcomes we have for all. And I think the other thing I heard both of you kind of speak to is that it's all of the systems. It's not just, our mental health system, our substance use disorder system. It's about healthcare. It's about criminal justice reform. It's about socioeconomic, like supporting people so they can afford to pay rent or have a place to live and have the supports in place that they need. So really, great conversation. I wish we could stay on kind of all day long. How about, and this will probably be our final question, maybe one more depending on what y'all say, but how about, do you have any stories kind of success stories that you'd like to share about the services you've provided and what you what keeps you going on the days when it's really hard and you think back to this story or this person's story and it helps keep you going. And maybe we'll start with Raina.
Sure. Thank you, Karen, for sharing also, I think, your own experience of being confronted with the, what we call moral injury of needing to participate in a system that you know is broken and that you may know is maybe causing harm simultaneously, because that is what we see from folks who've been coerced or forced into care, is that their suicidality outcomes are not better. In fact, in many cases, they're significantly, they're harmed by the system. They come out worse for the wear. I think success stories are so, I could just run through quotes. I think it's funny. I think some other nonprofit professionals would laugh at me, but I love reporting season because we do get to harvest caller anecdotes and ask our community to feedback information about the services they've received. We do larger quantitative quality assurance, and we look at outcomes that way, but the actual quotes and the personal stories are really just myriad, and it's really wonderful. I think because, of course, I'm maintaining confidentiality with our callers, I'm not going to share any specific case examples, but I think that the patterns that I see between return callers are really beautiful. We have folks who access our services on a daily, weekly basis. We have a limit of 3 calls per day, and some folks use that either for short or for long periods of time. I know from my own experience working both with a lifeline, with a 988 center, and also with a 211 service, and now with the warmline, that we have callers who cross over all of our programs, who use us for different reasons, who have good and bad experiences with our different call centers and prefer or don't prefer the others. And those return callers are a really important part of our ecosystem, and are also in some ways like maybe falling through the cracks and unsupported by other services that could be supplementary. But I just have a lot of affection for our regular callers. I think a testament to our service as well is when we look at our return rates, we also look at huge gaps of time. So folks will use our services. They've learned about us in the midst of a crisis or near crisis experience. They use our service for a while, and then months or even years later, they contact us again when they need support. They remember that we were there and that we were helpful. And this goes for folks who are experiencing, emotional upheaval, but also for folks with chronic mental health conditions that they themselves are on a recovery journey towards. We really emphasize that recovery, that living with a mental health condition of any kind, or just an experience is challenging. Not a lot of folks use that medical language, but just living with your mental health is a lifelong journey. There are ups and downs and challenges and bumps in the road. And I think we see folks returning to us and learning about us from other folks who've accessed our service, which is keeps us going.
Yeah, absolutely a success too, right? Because you've provided them a connection and a safe spot. So great. And how amazing to have had that experience where you got to be kind of in those 3 different pieces, like between 211 and the call center and that warm line. It's really amazing. So we're so lucky to have you in the world serving our folks that need us. So how about you, Jonathan?
Well, we have the honor of being in the darkest space someone can probably get to. And it really is an honor. It's a very intimate place, and people who let us in, do so, and we get a lot of feedback about the lives we save. I mean, technically, people are actually calling our feedback line and leaving messages saying, "I'm alive." I was working with someone the other night who said, "I think I'm going to live to jump another day." And it was sort of a dark joke, but his point was, "I'm not doing this. I've left the bridge." I think that's very validating. We did have a case where a chap was was able to be dispatched to a crisis receiving site. And we were able to bring him into the crisis receiving site, and he kind of liked it. And so we had an example of a person coming from an acute psychiatric crisis into a receiving site that's open 24/7. The reason we knew he liked it was because he wanted to come back into it. And he couldn't get there, so he called 911 and asked the police to actually drive him to the receiving site, which they did. And so, we ought to have a program that is not requiring law enforcement to be the first responder. But in this case, we got an opportunity to see not only a person in crisis benefiting from a program and appreciating it, but actually law enforcement, when they dropped him off, said, we're going to spend 2 minutes here dropping this gentleman off. And we're now going to go off and do the job we actually were hired to do versus spending hours in a hospital, hours in a jail, creating the inappropriate response. So I think for us, it's a systems response. It's a personal response. And we're seeing the opportunity to change the whole system.
Well, I think we have hit our time limit. I'm so grateful to both of you for the way you come into this world and take care of people who are striving for a connection. And I have no doubt in my mind that both of you and your teams have saved lives. And we're so very grateful to have you and all the other call centers and warm lines available here in California and throughout our nation. And so we want to thank everybody who joined today in the audience, and we hope to keep this conversation going. And just very grateful for both you, Raina, and Dr. Porteus, for showing up today and joining me in this conversation, and for all the work you do for the world. So thank you both. Take care.
Okay.
Thank you so much. Have a great day, you too.